OK, bonjour tout le monde. Mon nom est Anthony Duponi. Je suis psychiatre au Douglas. Donc, c'est avec un grand plaisir que je vous présente le docteur Martin Gignac, pédopsychiatre et euh, psychiatre légal, dont la formation médicale a débuté ici même à l'Université McGill, où il a obtenu son diplôme de médecine en 1998. Dr. Gignac a ensuite complété sa formation en psychiatrie à l'Université de Montréal, suivi d'un fellowship en psychopharmacologie pédiatrique au Massachusetts General Hospital, affilié à Harvard. Sa carrière remarquable inclut d'abord un rôle de psychiatre à l'unité des adolescents de l'Institut Philippe Pinel de Montréal. Dr. Gignac a également mené plusieurs études et publié de nombreux articles et chapitres de livres dans le domaine de la psychopharmacologie pédiatrique. Il siège depuis 2019 à la présidence du comité d'administration de la CADRA, l'Alliance canadienne des ressources pour le TDAH. De 2019 jusqu'à cette année, Dr. Gignac a tenu la barre du département de pédopsychiatrie de l'Université McGill et est devenu chef de la pédopsychiatrie de l'Hôpital de Montréal pour enfants. Il possède donc une vision intime des forces, mais aussi des faiblesses de notre département de pédopsychiatrie. Enfin, en dehors de sa carrière impressionnante, Dr. Gignac est un passionné de triathlon, ai-je appris, une passion que je partage. Je ne savais pas cela jusqu'avant la préparation de cette introduction. Il s'agit d'un sport très demandant qui demande de combiner plusieurs disciplines et je pense témoigne de son engagement vis-à-vis de la nature multidisciplinaire de notre travail par rapport aux soins en santé mentale des jeunes. Donc, nous sommes honorés de l'accueillir aujourd'hui pour partager ses connaissances et son expertise unique au travers de la présentation qu'il nous propose, qui abordera la question complexe des troubles de comportement rencontrés chez les jeunes avec TDAH. Donc, sans plus attendre, Dr. Gignac fera sa présentation en anglais. We are listening to you.
Alors, bonjour tout le monde. J'ai quelques défis ici à à- à mon bout de l'île par rapport à la réception, mais je pense que la transmission se passe bien, donc je suis très heureux d'être avec vous aujourd'hui. I'll switch gear. I'll discuss my experience and my understanding of what the literature can tell us about treating kids with ADHD with comorbid conditions with a specific focus on delinquency, but more specifically oppositional defiant disorder and conduct disorder. So I did some presentations in the past that were sponsored by the pharmaceutical industry. I don't intend today to talk about a specific medication or to just focus on one aspect of the treatment. So hopefully that will mitigate potential conflict of interest. ADHD is often seen as a school-based disorder. Often when we treat ADHD, we have this focus where we say, we want to make sure that kids have better grades at school. Unfortunately, no real studies have shown that ADHD treatment would improve school performance. The whole, I would say, point of treating ADHD is to improve functioning in a child and an adolescent and adult life. So the idea is to try to focus on the treatment of ADHD to improve self-esteem, mood disorders associated with the ADHD, prevent substance use problem. In terms of public health perspective, we could think about traffic accidents. I have a focus on legal difficulties, but we could also look into occupational, vocational, academic concerns, and also relationships. And we know that people with ADHD can have a higher risk of sexually transmitted disease and have a higher rate of teenage pregnancy. There was a very important study that was published initially in 1999. That study was conducted on multi-sites in North America. Dr. Lily Ekman at the Children's Hospital was one of the lead author on this study. And what they did is that they studied different approach for people with ADHD, comparing pharmacological treatment and non-pharmacological treatment and a control group. And they published very interesting data on that study. So if you're looking for one important, I would say, landmark study in the field, the multimodal treatment analysis, which is called MTA study, is one, I would say, group of papers that you should review. When you look at the comorbidities among the subjects that were included in that study, when they were child and adolescents, you could see that up to 40% of those subjects were suffering from ODD, and up to 14% were suffering from conduct disorder. And when you move into adulthood, you see ODD and conduct disorder disappear. So you don't see any of that in adulthood, even though we still believe that those comorbidity last into adulthood. Often they are, I would say, considered access to diagnosis, more like personality issues. However, we should consider the treatment, early intervention in order to prevent those negative outcomes later on. So usually ADHD has a genetic component, and it is there right from the birth. And then the child will develop over time a perspective that they are inadequate, they get grounded a lot, they are disruptive. And right when they start school, they start to be identified and tagged by teachers, educators, and often they develop disruptive behaviors because they have low self-esteem. If you have a feeling that you cannot perform well at school and you're asked to perform well at school, you may have negative reactions in front of this demand. So they often lack social skills. So I was just saying that initially you have low self-esteem, then during school, you see disruptive behaviors, and then as people developed over time, you're going to have more and more behavioral difficulties. Oppositional defiant disorder and conduct disorders are the focus of our talk today. So one of the important symptom cluster of those two diagnoses rely on aggressivity and impulsivity. In DSM-5, if you look into diagnostic categories, a lot of different diagnostic categories will present with impulsivity and aggressivity. So Tourette's could be part of the differential diagnosis. You could think of autism spectrum disorder. You could think of mood disorder. So some children do not have the classic manic symptoms, but they do present with a lot of irritable, aggressive, violent reaction, and they suffer from mood disorder. So it is important when you do a differential diagnosis and you have a presentation of a child with impulsivity and aggressivity that you consider those other options. Not everyone will meet the criteria for ADHD, conduct disorder, and oppositionality, and maybe you could consider other options in your line of work. There was a very important research done here in Quebec. That group of researchers was led by Richard Tremblay, who sometimes for residents, this is a bit unusual to ask about family history of delinquency, but it is something that we should consider when we wonder if somebody is at risk of future violence. So I'll go over a number of risk factors that we should take into consideration. So maternal depression, so early childhood attachment bonding would be considered a risk factor as well. In utero exposure to substances, Next slide, please. Family violence or exposure to trauma. We talk a lot about these days about complex trauma and how this can affect people's functioning in different settings, especially in youth detention. A lot of them have complex trauma presentation. Social determinants like low income would be considered a risk factor. The presence of community violence, and interestingly, some people advise family to move out of a sector where there's a lot of difficulty when there's a high rate of violence. Next slide, please. Peer rejection and deviancy training. So the peer influence play an important role, especially during the teenage years. Next slide, please. Parental behaviors. So these would be important to implement, especially at an early age. So having parental skills training would be very important to prevent future violence. And disordered parent-child attachment, I already talked about. When you think about the child himself, mental processes can also represent predisposition for future violence. So there is a trait, and I'm going to discuss that a little bit further down the road, but callous unemotional traits or limited prosocial emotion are part now of a diagnostic category in DSM-5 and should be considered a higher risk factor that is associated with conduct disorder. Emotional regulation or any internalizing psychopathology has been associated with also ODD and conduct problems. Social conditions, so perceiving fewer or more hostile social cues would be considered also a high-risk situation for future violence. Next slide, please. Executive functioning, so children with ADHD have a high risk of presenting conduct problems or oppositional defiance disorder. And language skills, a lot of the interventions that we rely on with these children are language-based. We expect them to be able to verbalize how they feel. A lot of them are ill-equipped to do that, and we should consider offering them some type of alternative treatment options like art therapy or like animal-assisted therapy, if they are not, of course, violent toward the animal. Should be considered alternative treatment. We do a lot of music therapy as well in certain units. So I think these will also be considered alternative therapeutic measures that could be helpful in order to help somebody engaging in individual therapeutic perspective. Next slide, please. So when you come down to have a checklist for psychiatric evaluation with a focus on disruptive behavior, these are all the factors you should be looking into. And you should make sure that you review them, because also they can lead you into developing treatment perspective once you have identified those risk factors. Next slide, please. There is a lot of research on the impact of extreme neglect on the development of the brain of a child. There is a very interesting cohort of Romanian children that were followed and that were taken out of orphanage in Romania and displaced to families in the UK. And Michael Rutter and other associates in the UK have studied the evolution and the development of these children. And what is interesting in terms of ADHD perspective is that those that have stayed more than 6 months within those severely neglectful environments have a much higher rate of ADHD in adulthood, regardless where they are placed after those 6 months. So the first 6 months in life seems to play a big role in how your brain will develop and mature over time. And of course, you have here a dramatic image of brain atrophy in a child that has grown in a neglectful environment for the past 3 years. Next slide, please. In DSM-5, there was this, I would say, movement toward differentiating symptoms of oppositional defiant disorder and trying to reclassify them in two big categories. So you have those angry, irritable mood symptoms, which are related to losing your temper, being annoyed by others, being angry, resentful, arguing with adults. And then you have the defense, headstrong behavior, and then you have the vindictiveness behavior. Next slide, please. Out of those 8 symptoms, you could maybe classify them in 2 big categories, and 4 symptoms of oppositional defiant disorder overlap with ADHD. So that means that if you treat ADHD, you will see, or most likely you will see, improvements in those symptoms that are mood related. That means that when you have a child that has a lot of oppositional defiant disorder, treating ADHD can improve oppositional defiant disorder. However, doing only medication therapy is not sufficient. You will need a multimodal approach, and you will need also to address those other symptoms that are distinctive and not related directly to the impulsive and aggressive difficulties that the child presents. So being stubborn, rigid, refusing to comply with the rules, having a low self-esteem, you will probably need to address that with psychoeducational intervention and, of course, behavioral intervention. Next slide, please. In DSM-5, the criteria for conduct disorder remain the same as we already know for many years and many decades now. So there are 15 criteria associated with conduct disorders, and those criteria have to be present for at least a year in order to come up with a definitive diagnosis. So having done one thing in your life does not mean that you meet the criteria for conduct disorder. So you need to have a repeated pattern of behaviors that will lead you to have problems with the law. So being aggressive toward people and animals, you have 7 criteria that relate to that. And then you have destruction of property, you have deceitfulness and theft, and you have violation of rules. At Pinel, we make a distinction between those that have dangerous behavior, and in French we say those that are disruptive, but they are dérangeants. So we call it dérangerosité. That means that you're annoying to your environment, but you're not representing a danger per se, because you don't confront people, you don't attack people, you don't carry weapon on you, but the way you behave is an annoyance for the societal norms. And so sometimes this distinction is important when it comes to doing some expert witness report for the court. Next slide, please. So in conduct disorders, for many years, there have been people looking into the different subtypes of conduct disorder. And when you try to reorganize, the different nomenclatures and terminology that has been used, you end up having more like 2 big categories of people with antisocial behaviors. You have those that have the psychopathic traits. So they are usually more the callous, unemotional, they're covered, so they're doing things under the table, they're delinquents, they have a cold profile. I often say that those that have psychopathic traits don't get arrested, but they get elected. So that's my dark political humor here. However, it's not a term that I use often to talk about a young adult or even a teenager with conduct problems. When you write in the chart of somebody that they have psychopathic traits, it's an important stigma for them for the rest of their life. So psychopathy traits are usually reserved for those that have multiple recidivism and that have been assessed by multiple experts, and at the end of the day, they never responded to treatments that were offered to them. Most of the time, though, I would say we see those with psychiatric traits, those that are under-socialized, that they are often involved in delinquency, and they get into conflicts, they're impulsive, It's often not planned in advance. When they do something, it's in reaction to a provocation. These are the overt types. So it's not hidden. It's done in front, in the eyes of everyone. They are aggressive type and they have a hot profile. Those psychiatric traits often go along with comorbid conditions. So ADHD, substance use difficulties, or even bipolar disorder has been considered an important comorbidity for those with psychiatric trait conduct disorder. Next slide, please. The conduct disorder with limited prosocial emotion is a specific subtype of conduct disorder. Those that have those 4 domains, they have no guilt, no empathy, they're not concerned by the lack of performance in the life, and they have a very superficial affect. So they tend to be quite seductive, actually, in the way they relate to others. And if you see one child with that type of presentation, you may consider them as being quite nice to be with. However, when you get to read their chart, you realize that they got involved in multiple different illegal activities. Next slide, please. The controversy around bipolar disorder in childhood has been mostly, I would say, fed by the fact that it is difficult to recognize a child in the prepubertal years with mood disorder like bipolar disorder. And there has been a lot of research and a lot of data and debate over the validity of such a diagnosis. When you come to young adult bipolar diagnosis or a teenage bipolar diagnosis, you don't see that many controversial paper on the subject. Mostly it's the early onset bipolar disorder that triggers a lot of debate in the scientific arena. Next slide, please. However, it's been recognized that affective disorder in juvenile offender population is there. You know, in some paper that go back to 2000, the cites a number up to 20% of juvenile delinquent individuals with bipolar problems. Next slide, please. And Dr. Biederman and his group in Boston, that has been, I would say, one of the leading group on the prepubertal bipolar problems, has been studying this overlap between mania and conduct disorder very carefully. And they were really trying to show that these are true comorbid conditions. When you look at the bipolar symptoms, they clearly overlap regardless if they have conduct disorder or not. Next slide, please. And when you look with the other lens and you look at the conduct symptoms, they similarly overlap regardless if you have mania or not. So that means that if you have this comorbidity, you should stabilize the mood in order to make them accessible to an intervention that could be offered specifically for conduct problems. Next slide, please. The child behavior checklist dysregulation profile has been used in order to identify those subjects that have high risk of having mood problems. And you could see that it relies on different subscores of the CBCL. So the anxious depressed subscore, the attention problem subscore, and the aggressive behavior subscore. When they are beyond the 70 cutoff line in the CBCL profile, you can consider that you have this dysregulated profile. And those individuals with the dysregulated profile have a higher risk of having mood problems. And of course, the debate is how are you going to call those dysregulated profile? And DSM-5 has tried to answer that question. Next slide, please. So the DSM-5 has come up with a diagnosis that we call disruptive mood dysregulation disorder. And the debate is, should they be called bipolar profile or the dysregulated profile? Of course, the group in Boston was very strong about calling them the dysregulated profile and the bipolar profile. And I trained with that group, so I've known the literature from that group quite well. Next slide, please. And there was this group at the NIMH in Washington that says, yes, this overlap between the mood disorder and conduct disorder exists. However, we're going to call it differently. Next slide, please. So in DSM-5, what we have right now is that diagnosis that is called disruptive mood dysregulation disorder. It's based on verbal or behavioral, aggressive, violent behaviors, where you have temper outbursts that are inconsistent with developmental level. You have temper outbursts that occur on average 3 or more times per week. And what differentiated from ODD, for example, or other types of impulsive reaction is that in between the temper outbursts, the mood is persistently irritable. So they are dysphoric all the time, and they have aggressive and violent outbursts in between those, the different, well, they have episodic violent outbursts. Next slide, please. So the diagnosis should not be made for the first time before age 6 or after age 18. So this is to try to differentiate the developmental level. So if somebody starts to have those reactions after the age of 18, you should look into different diagnostic subcategories. Next slide, please. So with Dr. Renaud, who's a psychiatrist at the Douglas, and a group of people, including Dr. Torian, at that time he was a psychiatric resident, we did review the literature on the treatment options for cardinal symptoms of disruptive mood dysregulation disorder, DMDD. And for the remaining minutes of my talk, I'm going to try to convince you that the main treatment that you should consider when you have conduct problems with or without the mood presentation, with conduct problems and ADHD, you should consider psychostimulants as the first option. And this was the conclusion of that study. Psychostimulants are being prescribed in most of the time and have positive impact in most patients. Next slide, please. So the guidelines that I was referring to earlier about the psychosocial intervention in oppositional behavioral conduct problems and aggression in youth that has been published, the Kenyan guidelines, you can find them on the website that's called readycanada.org, and you'll have access to a number of slides that can be quite useful. And those slides were designed in order to help people that are in the academic center to teach about those conduct problems. Next slide, please. Those guidelines have, I would say, consider psychostimulants as being an important treatment consideration for that population. And of course, if you were working in 1974 and you were considering the prescription of psychostimulants, you had one option. It was called Ritalin. And the disorder, ADHD at that time, was called minimal brain damage, so the MBD. Next slide, please. Now we have more options when it comes to the treatment of ADHD. I think Anthony, Dr. Gifuni mentioned earlier that I'm the current president of CADRA. I don't get paid for it, so in a sense, it's not conflict of interest. But we have this very nice table where we summarize all the treatments that have been approved by Health Canada. And most of the treatments, if you look at the first two categories of treatment, you're going to see that most of them are long-acting psychostimulants. And you have amphetamine-based products and methylphenidate-based products. You also have non-stimulant products that are approved for ADHD, atomoxetine and guanfacine XR. Those treatments can be interesting for comorbid conditions associated with ADHD. But when you look at the core symptoms of ADHD, you end up finding better effect sizes with the long-acting psychostimulants. Next slide, please. So The Texas algorithm was published sometimes in the years 2006 or 8, and it's been modified in order to follow the guidelines of CATRA. And the idea is to, if I summarize it in a few words, you try a long-acting stimulant when you come to decide to treat somebody with ADHD, and then you try the other class of long-acting stimulants. So if you start with methylphenidate, you then switch to amphetamine, therapeutic amphetamine. Once you've tried these two psychostimulants, then you can move on to the non-stimulant strategy. And of course, you have, by looking at this slide, other treatment strategies that you may consider, like the non-stimulant, but also some antidepressant medication like bupropion has been studied as an interesting antidepressant for people with ADHD. Next slide, please. There's also in the Texas algorithm a specific review of treatment algorithms for aggressive behaviors associated with ADHD. And basically what's recommended is to follow the ADHD treatment algorithm. And then if you don't have the results that you want, you add a psychosocial intervention like behavioral intervention or psychoeducational management. Ideally, if it's conduct problems, it should be multisystemic. That means you implement it in different, arena where the child is spending time. And then you can move on to other treatment strategies, like atypical antipsychotic medication can help stabilize the mood. They can help with impulsive, they can help with aggressive behaviors. You can also consider the traditional mood stabilizing agents, mostly the valproic acid and lithium have been studied, and this is how the algorithm is being developed right now. Next slide, please. In 2015, the treatment algorithm was reviewed by this group of researchers. These are all Canadian, and they did meta-analysis of all those products, and I'm going to show you the results on the psychostimulants. Next slide, please. So the psychostimulants for people with ADHD were showing a pretty decent effect size of 0.5 if it was measured by parents, and it was up to 0.7 if it was measured by the teacher. Next slide, please. The conclusion of this meta-analysis is that if you compare stimulants to the non-stimulant product, you have a better effect size with the psychostimulant. And so if you have conduct disorders with ADHD, that should be your first-line treatment. Next slide, please. And then you have also similar meta-analysis that was done with the atypical antipsychotic. Next slide, please. And they were able to show that one of the most effective medication that was reviewed was risperidone. They did the same thing with Abilify. They did the same thing with quetiapine, and they had, I would say, mixed results because they didn't have enough study. But Abilify is used quite often in order to stabilize the mood in that population. Next slide, please. And of course, they did compare the other traditional mood stabilizing agents like lithium and valproic acid. And they concluded that we have, I would say, low quality evidence to recommend lithium and valproic acid in that population. It is used sometimes in severe cases that did not respond to other approach. And they didn't consider these treatments like first or second line treatments because of the high rate of metabolic syndrome associated with the atypical antipsychotics. So those treatments can be considered, but after you go through the ADHD algorithm, so long-acting stimulants, maybe a combination with the non-stimulant medication, and then consider those atypical antipsychotics later on. Next slide, please. So to end on this presentation today, we're going to talk about psychosocial intervention. The psychosocial intervention for disruptive behaviors should rely on a solid background, I would say, an environment, a living environment maybe societal support network that will allow people to get services rapidly when they need it, when they detect that a child is at high risk of disruptive problems. And then you should consider systemic therapy. So working with the parents, parental skills, improving communication, validation within the family can have major impact on preventing the negative outcome. And then you should consider the individual therapy. So CBT, cognitive behavioral treatment, has been identified as a very powerful treatment. And I would stress the fact that it is individually based. Group therapy for groups at risk of conduct disorder has been considered sometimes iatrogenic. So people can become more antisocial when they join a group of people that have similar problems. So you don't want to become like a deviancy training treatment center where people come in, they make friends with delinquent problems, and then they end up being more delinquent at the end of the day. Social skills can, of course, be also very powerful. And you have to plan for crisis intervention. If there is an outburst, if somebody is out of control, where should they be placed and where should they go? Hospital is not the best place to send them, so they should be probably connected to the BACHA network or the youth protection network. Next slide, please. If you work in this line of population, you have to know about the criminal law. So you have to know about the YCJA, which is the Youth Criminal Justice Act, or the LSJPA, which is the translation, la loi sur le système de justice pénale pour adolescents. It is important to understand that those laws, contrary to the youth protection law, have a focus on protection of the public. So you want to protect the public. This is the first thing you should have in mind when you do an assessment. And so you want to hold people accountable through measures that are proportionate to the seriousness of the offense, degree of responsibility of the young person. And that second sentence, the degree of responsibility, is based on the level of maturity of the person you're evaluating. So we have in our criminal system in Canada this notion that we can't consider them just small adults. We should consider that they don't have fully mature yet, and they should be treated by the criminal justice system as people that have a high potential for rehabilitation and social reintegration. So the idea that we're going to develop programs and treatment programs and not try to replicate a prison environment is very important. So supporting crime prevention by referring young people to programs, agencies in the community to address circumstances underlying their offending behavior are quite important. Next slide, please. So the youth system must be separate from the adult system and must be based on the principle of diminished moral blameworthiness and culpability. So this is an important principle when you work with those youth. Next slide, please. And I'll finish by just saying a few words about how you assess the violence risk in that population. So we have an instrument that we use and we refer to. It's called the SAVRI. It's the Systematic Assessment of Violent Risk in Youth. And these are the factors that you can rely on when it comes to looking at the history of the individual. Trying to predict violence is like trying to predict forecast. So if you predict forecast, you have to use the principles that you use to try to identify where am I on planet Earth when I'm trying to identify potential meteorological phenomenon. So if you know your continent, so you know the background of this environment and what kind of meteorological phenomenon occur in this part of the world, you're going to have a better understanding of what the risks are. So history of violence is a number one. History of nonviolent offending. So history of violence doesn't have to be going through court in order to count this as a factor. However, the history of nonviolent offending, you only rely on those that have been recognized by the court system. Early initiation of violence. So that's another important classification for conduct disorder. So if you started to be violent before the age of 10, your risk of being violent during your adult year is much higher. Past supervision, intervention failures, the history of self-harm or suicidal attempts should be considered high-risk profile. History of violence at home, childhood history of maltreatment, parental caregiver criminality, early caregiver disruption. If you've been placed or abandoned, you have a higher risk of being violent. And poor school achievement is also an important one. Next slide, please. You should know the season you're in when you try to predict mythological phenomena. So those are the social factors. So peer delinquency, peer rejection, stress, coping strategies, poor parental management, lack of personal social support. So you don't have resources around you. And community disorganization. If you have a very high risk environment where there's a lot of drugs, a lot of violence, a lot of socioeconomic difficulties, you will probably have a much higher risk of this individual engaging into violent behaviors as well. Next slide, please. And lastly, your individual factors are like, where are you in terms of altitude? So how far are you from sea level? The higher you are on a mountain, the more unpredictable meteorological phenomenon can occur. So having a negative attitude, that means that you value criminal behaviors to solve your problem. An example of that, I hear very often people saying, I punch him in the face and then he stopped annoying me. So that's the way to solve problems for some individuals. It's probably not the appropriate way to do it. Risk-taking or impulsive behavior. Substance use difficulty is a very potential, I would say, powerful risk factor for violent behavior. Anger management problem, low empathy, remorse. Attention deficit hyperactive difficulties, poor compliance to the treatment and medical recommendations, and low interest or commitment to school. And lastly, but not least, in the SAVRI, you also have protective factors. So you can use protective factors in order to try to promote, I would say, public health safety measures by trying to build on those protective factors. So strong family bonds, being engaged in the school program, and having resilient traits will certainly help you. Thank you very much for your attention. I do apologize for those technical difficulties. They were out of my control, but I'm glad that we were able to connect and to go through the presentation. So I'm available for questions. Hopefully this is going to work verbally. If not, you can write them in the chat, I suppose. Thank you very much.
Thank you, Dr. Gignac, for this really interesting and very, very relevant presentation. I think I'm speaking for all of us here. We'll see if there's questions. I think there's so many things we can sort of explore, as you mentioned, the sort of wide array of comorbidities that when we speak of ADHD and behavioral issues. So I'm sure there's a question in our audience, and they can be from anything from treatment, diagnosis. We have Dr. Gignac here. Don't be shy. I see Lena's raising a hand.
Yeah, thank you, Anthony. Thank you very much, Martin. This was very, very enjoyable. And thanks for putting up with the disruption and continuing with the talk. It was very helpful. My question was really on the DMDD concept, disruptive mood disorder, mood regulation problem. Of course, you mentioned that it's a new concept and we are going with the best possible treatment option with focusing on stimulants to reduce aggression and irritability. But originally, this was conceived as a early indicator not too far from bipolar disorder as such. So even now, I think, there's a lot of overlap with pediatric bipolar disorder. I don't know what is the impact of this diagnosis on prevalence of pediatric bipolar disorder as such. But how do we, as a prescriber, how do we decide the challenge between choosing mood stabilizer based on bipolar-like presentation versus choosing something like a stimulant, which may not work as well if there's going to be a bipolar disorder outcome in the future?
Yeah, I mean, right now, the MDD is classified as a depressive presentation in DSM-5. So it's like early childhood depression. And it goes with this theory that when you look at the cardinal symptoms of depression, you have either melancholia or irritability. The same applies also for bipolar or mania, where you look at the cardinal symptoms of mania, you have like euphoria, irritability, or like expensive or grandiosity. So you're correct that when you have the presentation of an irritable mood, you should be mindful that that might be aligned with bipolar disorder. And there was some work, I didn't have time to talk about it, but there was some work done to try to qualify better how the mood presentation is. So is it more like introverted, extroverted mood presentation in terms of aggressivity and irritability? And these could be signs that will lead you maybe to jump right away to using mood stabilizing agents. So for the time being, if you have an irritable child in front of you and there's not a strong family history of bipolarity, it is reasonable to consider psychostimulants as the first-line treatment, because a lot of those children may respond to the treatment of ADHD because that's an important contributor to their irritable mood presentation. But if you have a strong family history and the mood presentation is really like, I would say, the classic bipolar symptoms of euphoria, lack of sleep, talkativeness, hyperactive, like agitation, and then you have those mood components associated with it, probably it would be reasonable to start with an atypical antipsychotic. However, as I said, starting with an atypical antipsychotic comes with careful management because of the metabolic syndrome. That is probably worse in terms of impact in a child compared to an adult, because it seems like the children are very sensitive to those side effects. I've heard a lot that Abilify doesn't lead to weight gain in adults. Well, in child, I can tell you there's a lot of weight gain with any of the atypical antipsychotics that we have approved for that age group. So we have to deal with that.
Thanks, that's helpful.
We have another question in the chat that I received here. Can you hear me well? Given the lower rate of ODD in adults, what would be your recommendation for psychosocial intervention for adults? Would you avoid group therapy for adults, ADHD adults in general? Thanks. So I wouldn't avoid group therapy for ADHD. I wouldn't avoid group therapy for oppositional defiance disorder, but I would avoid group therapy for antisocial personality disorder and for conduct disorder. If you do group interventions with them, it's because you're going to do social skills training and you won't do like delinquency prevention. When you start talking about delinquency, you should do it individually because those may have a negative influence on one another. So that's for the part of group intervention for that population. In terms of psychosocial intervention for ODD,
Well, ODD in adults is probably also related to the poor self-esteem. So the intervention for anybody with oppositional defiant disorder is to try to have quality intervention, quality time with them. So in childhood, we'll recommend parents to spend quality time with their child to try to reinforce the attachment and bonding between the adult and the child. And then, of course, focus on structure, clear expectations, and clear demands. And adults, often I find that ODD children become, the future borderline personality disorder. So I guess the intervention you offer to borderline personality disorder could also rely on those principles of having a routine, having a structure, tolerating negative emotions, and trying to rebuild some fragility in terms of low self-esteem. So the more people experience success in life, the more enjoyable they are to be around. So try to focus on making sure that they find a way to experience success in life. I find that we put a lot of emphasis, especially in my line of work, on expectations that are not realistic for our patient population sometimes, and they end up failing, and those failures will entretenir, the difficulties that they have. It will augment their functioning difficulties.
I don't see any other hands. If I may ask one last question. You mentioned, still on the theme of psychosocial intervention, and often the system in which the children or adolescent is a contributor to the issues. Either they have ADHD and the environment contributes to them developing poor self-esteem, or they have aggression and it's difficult to sort of set boundaries anyway, in your experience, what are the most effective interventions with parents? Is there a specific pattern that you see with parents that it's actually very effective to intervene when you see this pattern of interaction between a parent and a child with behavioral issues, even as a psychiatrist?
Yeah. I find that we focus a lot on the behavior, what they did, like, they spit, they run, they hit, they scream. But sometimes we forget what were the triggers and what kind of lagging skills is behind the behavior. And I think if we can give parents a lens where they see that this is just the expression of their difficulty to meet the expectations, and that's why they had that reaction, we may refocus on how can we adjust our expectations to a level where we can experience success. So there is a very interesting program that's called Collaborative Proactive Solution. It's CPS. The lead researcher on that program is called Ross Green. If you want to search it on the web, it's Lives in Balance. And they have a very nice program where they try to focus on lagging skills, so emotional regulation skills, cognitive rigidity, social skills deficits, and they try to intervene in a way somebody can build those skills. We say often in psychiatry that pills don't build skills, it only reduces symptomatic presentation. But then if you have a program where you can build on those skills, you can have more successful intervention. In certain cases, behavioral management work well. You give reinforcement, you give consequences, that work. But in children with a lot of psychopathology, especially those with severe ADHD and conduct problems and ODD, we get stuck in those reinforcements and consequences. And sometimes we should try to move away from that and try to really explore what are the lagging skills and try to build on those lagging skills.
Mm-hmm. Yeah, thank you. I can confirm the CPS is a very interesting method. There's a lot of resources and books written for professionals and for parents and even for school administrator. It's a whole program. Well, I think we're about time and we'll need to conclude, even though we could pursue that very interesting discussion. I'd like to thank Dr. Gignac for his presentation and everyone for participating. Thank you. And we are giving you our next invitation for the next presentation in our series in Perspective in Mental Health. This will be held in December, so check your calendar. The invitation is already on the website of the Center for Excellence in Mental Health. We'll be receiving Dr. Singh from Stanford. We'll talk about specifically mood disorders in youth. So thank you all.
Thank you.
Thank you. Bye-bye.
Bye-bye.